It's Michael Gatzoulis. I'm a professor of cardiology with an interest in congenital heart disease, based at the Brompton here in London. The initiative of the ACHD Forum 2020 came about the need to communicate information on this global threat of COVID-19 that spares nobody. And I'm delighted to introduce to you a panel that we have for the discussion, the first part of the webinar, and will allow for adequate length of time to take as many questions and address concerns that you and we also may have regarding this pandemic. So the first presenter is Rob Nicol, who is the past chair of the Somerville Foundation and a trustee to the foundation. The Somerville Foundation is the probably oldest patient association for goods or ACHD. And Rob will introduce us into the session. I will follow presenting an overview of COVID-19 and its relationship and impact on cardiovascular disease, and obviously because of our interest and focus, congenital heart disease. This panel is particularly strong because we have two colleagues and friends from the Lombardy region who have been at the center of the storm of this pandemic. So we have Massimo Chiesa, who is the head of the Milan group and a designated ACHD service. So he will tell us about their experience to cope with the pandemic. And we have Paolo Ferrero, also from Lombardy, who is the head of the Paediatric and Adult Congenital Heart Service in Bergamo. And in fact, we'll reverse the order, and Paolo will present some very interesting and unique data from their experience in Lombardy. And then Massimo will give us additional comments. And then last but not least, we have Rachel Adam-Smith from Yorkshire. Rachel is a patient of ours with congenital heart disease. She's going to give us her perspective and the worries which are not confined to her, but to the patients and to the rest of us about the condition. And she has some questions to start, and then we'll be open to all of you for comments and questions. So before I ask Rob to start, I would like to give a big thank you to Livemedia for supporting this. And they are really ahead in terms of education and communication of information, and very supportive of this effort. And of course, thank you all for being with us today, and thank all the speakers in the panel. So, Rob, thank you.
Thank you, Michael, and thank you everyone for coming to watch this today and listen to us speak. A big thank you to Michael and obviously his medical colleagues there across the continent. This is such a pressing matter for everybody that's got a congenital heart defect, and there are lots of questions. I'm not qualified to answer most of those, so I'm going to be quiet in a minute, but I just thought it'd be worthwhile setting the scene from a patient organization perspective. So if this shares, I think my screen should be shared now. So this is a proper storm in the minds of many congenital heart patients, and they're in a very worrying time. So what does that mean? There's general confusion, I think, amongst the patients about what this means for them. They're getting mixed messages from different organizations, different representative groups, and from hospitals. We have this concept in the UK of shielded and at-risk individuals, and what the difference is and why some people have fallen into one category or another has made a lot of people anxious. And there are questions out there as to whether I've been correctly categorized or not. Have mistakes been made? And We do see some patients changing, their status has been changed once someone's questioned it. I think there are real concerns over whether they should be attending hospital, either from a COVID-related perspective, if they've got the signs of the disease and it's mild, or whether they're attending the hospital for some other reasons. And I also think there's real fear about the future of their services, and especially their doctors and nurses. There's a very close relationship between many patients and their specialists that look after them, and I think there's genuine concern that they may well fall sick, which I'm sure is a concern that their doctors and nurses also share, but that's also playing on their minds. And the fifth area is delayed planned interventions, and the suitability of clinics being run by video, which is something which is now starting to happen for obvious reasons. So these are the sort of 5 broad key concerns. Hopefully the discussions today will address some of these. From a charity perspective, and it's probably worth throwing this in because we are the main charity, in fact the only charity in the UK representing adults, and our demand is greater than ever, whilst at the same time we're seeing mixed advice out there, so it's not as clear cut. There's not the time available for people to consider these things like they would have done previously, so that creates more requests for information. From our point of view, it's difficult for us to reach clinicians because they're busy for obvious reasons, but that means a delay, more delays, more anxiety, etc. We're also in a position where our own staff have got their own challenges. We've had to furlough people, we've had to restrict hours. As you'd expect in a charity, they're not actually reducing the number of hours they work, but all these things are pressure, and they're working remotely. So they're not together in the same office, they're having to work by computer, etc. And that starts to disconnect various things. And as a charity, we've got no income. That's a problem that charities are obviously suffering with across a whole range of services, but no income, maximum demand, that is a problem. So the answers, and I'll shut up after this slide, is, I think communication is absolutely essential. We've got to make sure that that's clean and timely and precise. We need to speak with one voice. That's a problem when you have hospitals and groups talking slightly differently, and patients will pick up on those nuances for sure. And events like this need to be planned over the coming weeks to make sure that we can keep that communication absolutely smart. So I'm going to be quiet now and pass back to Michael to continue.
Thank you very much, Rob, for your comments. We share some of your concerns, and we are all together in it. And I think the reality of it is this is an unprecedented situation that we are faced with, both in terms of the virus and the pressures on healthcare. And I'm confident that at the end of this webinar, we'll be able to reassure our patients. And as you said, communication is key, and this is the main driver for holding this webinar. So without further ado, I would like to present the background to this disease. Let me see. So what I should say about the Brompton and also St. Thomas's, as you probably know, are major COVID centers. And we have seen the last 2 or 3 weeks a major change in our practice at our own institution, being part of the national effort to prepare and defeat this aggressive virus. So we'll come back to this. One of the legitimate concerns is how can we at the same time maintain the tertiary care that our patients need. And there have been obviously adaptations in our practice, and we are available to our patients. There are short and long-term plans. And may I say that at the end of this difficult period, which is going to take some time, our practice is going to be different from what it used to be. But that should be for better care and a better journey for the patients. So let me see. Viruses epidemics are not something new. They've been with us over the millennia. And a most notable example is the Spanish flu that had about 50 million people dying, more than the kind of deaths of the two world wars. Coming to coronaviruses, there is a strain of the virus, which 3 or 4 of them, which give very mild disease. But you can see here on this editorial from the International Journal of Cardiology from last week that there were the first epidemic of SARS-CoV in 2002 that was contained. There was a second epidemic ongoing, the Middle East respiratory syndrome, which started from Saudi Arabia in 2012. And unfortunately, our world was not prepared to deal with the third pandemic that we're all faced with, which started in December of last year in China. I think the first thing to say is that the vast majority of patients have a mild illness, which is a flu-like illness. And from the data that we have, it appears that probably about a quarter of patients have no symptoms at all while they're exposed to the virus and with time become immune. There is a proportion of patients, about 15%, who have severe disease, and only a small minority, but obviously important minority, that develop critical disease later on in the process, in the later stage. And these are the patients that require intensive care support and facilities. You see at the bottom of this green box that the case fatality rate varies greatly between places. And I think one has to question the accuracy of data sets as they have emerged. I think it's fair to say that in Korea, they were quite proactive in tracking the disease, testing, and also respecting the so-called social distancing measures. It was suggested that the Italian population is perhaps older than Asian countries, and we'll come back now with real data. I really value Massimo and Paolo being with us. These are the stages of the disease. On the left panel, you see the blue arrow, the early infection, usually with flu-like illnesses, symptoms. And for the majority of patients, self-terminating before it goes to the pulmonary phase, which usually is after 5 to 7 days, that you have more marked respiratory distress. You may have some hypoxia. And I think this is the phase that our Prime Minister is currently nursed at St. Thomas's Hospital. So a disease that spares nobody, clearly. And then a small minority of patients who may have an excessive response, inflammation response, that they go into the acute respiratory distress syndrome and they're in trouble and they need full intensive care support. At the moment, the global effort is to change the first peak that you see here, the orange peak, into something which is delayed and smoother. Because if we had the first peak, let's say in the United Kingdom, despite this enormous effort at national level to prepare for it, there will be no capacity to support the vulnerable population that goes into the critical phase that requires intensive care therapy. Just not possible. And that's what we're seeing to some extent, and sadly happening in New York. So the emphasis at present is to push this smoother peak to later on allow for better intensive care facilities and more available facilities to develop, and B, in the process, to start having a significant proportion of the population immune. So the message, stay at home, is absolutely crucial, including Easter, and I think this is going to take some time. We need to be patient with it. These are the symptoms, as I said at the beginning of the exposure. Early symptoms may be flu-like, and the majority of patients would recover within a week or so. But some patients, the fever will persist, they will develop respiratory distress, and obviously they will need more attention. And some of them hospital admission and intensive care support. Some other characteristics of this new disease, as we are getting to know it, is that loss of taste and smell. Also, we see some vasculitic phenomena. Other organ involvement is not uncommon in patients with critical disease. This is data from Wuhan, the origin of this pandemic in China. And what you see here in the red box, the patients who have cardiac involvement and arrhythmias, which are common complication, which is a percentage of about 20% of those hospitalized. Clearly, the first organ that is hit by this aggressive virus is the lungs, the respiratory system. But there can be cardiac involvement. And for those sick patients, kidney failure is common. So in our very different environment at the Royal Brompton Hospital with multiple intensive care wards converted to, I would say that more than 50% of ventilated patients, it's all ventilated patients with COVID, but we do have green areas for selected patients that need admission, but those ventilated patients, many of them are filter kidney support. What are the mechanisms of cardiac injury in COVID-19? There may be direct damage from the virus through the AC receptor mechanism. It may be, as we saw in the previous graph, there is extensive pro-inflammatory surge that is affecting the cardiac myocytes. And it may also be that the patients who have very severe ARDS, lung disease, that through hypoxia, or it may be all of them. Age is clearly relevant. Older patients are more vulnerable to this aggressive disease. And in many ways, this is a relative advantage for our adult congenital heart patients because they're younger in relationship to the general population. There are younger patients affected by the disease, but and although we see very small numbers of patients dying in childhood, these are indeed very small numbers. So the vast majority of casualties from this are patients who are older than 60. And it may also be, and I think the data from Lombardy are very revealing in that sense, even for the congenital population, and the message to us all that it's not just age per se, but it's comorbidity that comes with age, such as obesity, lack of physical activity, systemic hypertension, maybe diabetes. So who are the high-risk groups? As we said, age older than 65, all the patients who are in a sort of confined space. We had the tragedy in Scotland of 13 patients dying from COVID, almost certainly in a nursing home. Patients with underlying chronic lung disease of moderate severe severity, immunocompromised patients. I'll come back to this, but that includes smoking too. Obesity is a risk factor, diabetes, and some of it is, modifiable. pre-existing kidney or liver disease. For pregnancy, the data are not clear-cut, and I'll come back to on this in a moment. And the background of serious heart condition, which is the source of a lot of conflict and conflicting information that you get. So I will discuss this again, but I think the majority of adult congenital heart patients who do not have other comorbidity outside their structural heart problem, and they're not in heart failure, and they're not immunosuppressed, a very small minority maybe, are low risk with this pandemic. We somehow have a consensus that the more extreme end of the spectrum, those with a single ventricle physiology, and some of them with cyanosis, I think undoubtedly patients with pulmonary hypertension, maybe patients with a systemic RV, and those with previous decompensated heart failure or cardiomyopathy. I think transplant patients, again, because of immunosuppression, and as you said, other comorbidity like kidney or lung or liver disease. A lot of consensus as to whether somebody who is on ACE inhibitor should discontinue because of this potential mechanistic link. I think the advice currently is not to change your medication unless there's a specific reason for it and after consulting your provider. The pregnancies I alluded to, there is nothing to suggest that pregnant women are more exposed to the virus, and they need to take the measures that all of us, patients, we, the whole public need to follow. There is, again, conflicting data, initially suggesting from China that there is no vertical transmission. There is some data now to suggest that vertical transmission is probable on small numbers. I would suggest that you visit the Royal College of Obstetricians and Gynecologists. Their site has a regular update, very, very informative. I think breastfeeding is not an issue, but if the mother has COVID-19, she needs to take all the precautions, trying not to transmit this to her infant. That being said, infants, even those born to mothers with COVID-19, whether this is vertical transmission or peripartum, their prognosis is very good. Some advice, and this is an extract from Adrian Kovacs from the very successful webinar like ours that the American Congenital Heart Association ran last week. So I think this social distancing is a misnomer. It's a physical distancing that you need to apply. Keep about 2 meters apart from people, so to minimize the transmission of the disease. It should be embracing socially people. This is the opportunity to do a better job. And we must obviously use technology. So embrace our family, embrace our friends, embrace colleagues. So it is an opportunity. It's not social, it's a physical distancing required. I think our congenital population, their families, have excellent coping mechanisms, and they are an inspiration to us every day in our practice, being told that they or their children have congenital heart disease, subjected to multiple operations, some of them with physical disability, and uncertainty about the future, not only with this crisis in general, we're getting better, and yet having a positive outlook to life. So there are existing coping mechanisms to take you through this. I would suggest personally to limit exposure and consumption of news. I would like to see that we focus on what we can do and what we would like to learn and make better out of this period of upheaval for all of us. Having to spend more time with family in confined spaces, I think we need to be more patient and tolerant of others and of ourselves. Stay in touch with your health providers. There's a fantastic framework in the United Kingdom. There's been a lot of focus on it to make it better, but it's a fantastic network and people committed to it. So stay in close contact with them. And if help is needed, ask for it. So we must take better care of ourselves. And I know it's easy for me to say, not easy to apply, particularly for people who live in urban areas and in small confined space, a lot of people. So it's not going to be easy. But maybe you can modify our lifestyle. It cannot be there through this difficult period to a sort of 10 to 6 and the routine that you used to have. Maybe that we need to go out at a different time, that we don't interact with too many people and still maintain physical activity. Fellows and colleagues at the Brompton know that we care a lot about being slim and athletic. It's not about the appearance, it's about the benefits that brings in terms of immune system, in terms of arrhythmic propensity, in terms of mental and physical well-being. If there is an opportunity to give up smoking, this is the one. We need to improve our diet and optimize our weight through this difficult period. And maybe there is time, we've never had this time, to do something different. Maybe take up a hobby, arts and crafts, read a book, and take better care of ourselves and others. You've seen these slides, colleagues are working in the field about how can we do better for congenital heart disease, because, as I said, we have a good framework here, but it's not tip-top. It's not what we should be aspiring to 21st century. And I'm hopeful that through this crisis, and when we survive it, and we will, that we come up at the other end better as peoples globally, but also our application of tertiary care for ACHD and other areas. And we must use and harness technology, not only the teleclinics which are running, and I can tell you, I'm having discussions with my colleagues, when this is all over, we'll be running in parallel to the conventional clinics, teleclinics, because they have merits, and some of the patients do prefer them. We must use artificial intelligence for risk stratifying patients. Remote monitoring is now here, must use it, and we must do a better job in terms of education. And again, we can use technology for this. So it is an unprecedented time. The storm is now coming to the United Kingdom. We are prepared to a large extent to face it. I think we need to be patient here. This is where I come from in Greece. It may be that it's not this summer. Maybe it's next summer. But I'm confident that we're going to weather this, and we need to stay at home until further notice. Still uncertainty, and needs to be decided when we're going to be, freeing some of these heavy measures. We need to stay healthy, strong, and together. And just to say that there is a lot of legitimate information on the web, starting from the Somerville Foundation, that do a great job. I think your own provider, including the Brompton, and my colleagues and myself are trying to put into it as much information as it emerges. The British Congenital Cardiac Association, I think the American Congenital Heart Association, the NHS, and other legitimate sources to guide you through this difficult period. Thank you. So what we discuss with my colleagues in the panel, that would be better for us to have the Italian experience now from Northern Italy, from Lombardy, and we'll have Paolo presenting, then we'll have Massimo to follow, and then perhaps if there are any clarification points to make within the panel, and then we'll go to Rachel. She'll give us the patient perspective and some questions that she has, and then we're open. I see that there are numerous questions, hundreds of them. We'll try to prioritize and make the key points that are worth communicating. So without further ado, Paolo from Bergamo. Thank you.
Good afternoon, everyone. Thank you, Professor Gatzoulis, for giving me this opportunity to share with you some thoughts, some feeling, and maybe some useful experience. I would like to start from the beginning of the history and go back to the 21st of February when all the history started, at least in Lombardy. At that time, we were just working as a regular day in the hospital, and we heard that in Congenital, which is a small city 1 hour from Bergamo, there was admitted the first case with COVID-19. And at the same day, we heard that some other patients were admitted in our hospital. That weekend, I was enjoying a walk in the old city, and you can see here how many happy people going around and for a walk in this square. 1 week later, this was the situation. We started to hear sirens of ambulance coming to the hospital, and we started to see the fear and the concern in the eyes of our colleagues, and we suddenly understood that something unusual but very scary was going on. The following night, I started to have fever and cough, and I started my quarantine at home, 1 month of isolation, and that just ended 4 days ago after 4 positive tests. Probably this picture has done the round of the world. There is a very scary picture showing a long queue of trucks bringing the bodies of dead people from Bergamo to the crematoria. And just to give some numbers, Bergamo was particularly hit by this virus, and 1 in 4 of the total deaths in Italy are from Bergamo. And probably we are highly underestimating this figure because a lot of elderly people died at home without any test. And this means that probably an entire generation has been completely decimated. So I in those days, I started to think about colleagues that I used to work with, that I learned that were in the ICU in poor condition, intubated. I was aware that some of our colleagues that just retired were died. And when I start to recover and the physical discomfort settled, another kind of suffering came up, which was related to the forced isolation, the endless feeling of impending catastrophe, and that we were listening from the TV news, and the constant concern about relatives and friends. At the same time, I start to feel very empathic with our adult congenital heart patient, and I started to think that probably they were very scared in listening to the expert on the TV that were stating that because of their condition that we were likely to die if they would have caught the virus. So I started to call some of these patients, and suddenly I realized that there was plenty of opportunity for me to be useful just by advising them and listening to them. And I also realized that other colleagues and friends like Massimo were doing almost the same things in different ways for their patients. So we talk each other, we start to contemplate that probably this could be a unique chance not only for help our patient, but only to generate important data. So we agreed on a common protocol to follow up this patient by phone and to collect systematically the data. This what I'm showing here is the based on the data from Bergamo only, but we are going to merge the 2 databases, These are almost 500 patients from our outpatient clinic. And I think that we will end up with more than 700 patients. As you can see here, most of the patients that we follow, of course, come from Lombardy, and most of them specifically from Bergamo, which is the hot area. This is my protocol to interview the patient. I will not go into much detail, but just want to underline a few concepts. We try to minimize the clinical exposure of patients to the hospital. At the same time, we try to maintain a high level of medical psychological support for our patient and their family by phone. I also gave patient a number that could use in case to notify any changes in symptoms. So now we also have some kind of follow-up for this patient. This is our population, as I said, around 500 patients. Of course, we prioritize the more complex patient, and probably you can see on the right hand, the figure is covered by the screen, but as I said, probably we are underestimating the number of patients because we could test only 3 patients from our cohort, but 90 patients altogether, which means 20% of patients had specific symptoms, which means a combination of fever, cough, loss of smell and taste. This is just to show you how these numbers are divided in different categories, and again, there are a lot of patients symptomatic within the complex patient, and in particular with palliative patient, univentricular patient. What happened about what we did was to, as I said, to try to keep all these patients at home. What we did is based basically on local protocol, hospital protocol, institutional protocol. This is not guidance, it's just what we are doing. So the priority was to keep liaison with the general practitioner to monitor symptoms and saturation whenever was possible, to convert all the device control with remote device monitoring, and so on. In terms of medication, there is now in place, at least locally here in Lombardy in our hospital, the protocol to start hydroxychloroquine azithromycin in this patient and the low molecular weight heparin. All these patients were kept at home, so 88, the vast majority of these patients were kept at home, 88 patients out of 90. Only 2 patients were hospitalized. And I have to say that one patient had only very mild symptoms, and the other one was hospitalized, but again is disturbing. I just spend the remaining few minutes to present 3 emblematic patients that probably can give us some insight, some information. Complex patient, artery switch, so quite old patient compared to our core, because of course patient who undergone artery switch a little bit older. And this is a patient that we follow. We just underline in the demographic and the BMI, which is normal. So the patient was pretty fit. And he assessed the need for atrial fibrillation. And that figure that you can see in the graph is are the numbers of patients that were growing during that period because of the spread of the virus. So I assessed initially to the hospital, which in the area that was the first lockdown area in Lombardy. After 1 week, he started to have back pain, very specific symptoms, no fever, no other symptoms. We went again to the same hospital, they did the CT, and they found this interstitial pneumonia. At the time, there were almost more than 15,000 patients infected, or at least notified. He was hospitalized. He didn't need any ventilation, any medication, and he was successfully discharged after 1 week. The second patient is the same anatomy, but completely different presentation. So he is an obese patient with comorbidities, diabetes, renal failure, etc. And all the history started again with worsening cough. He was, in this case, admitted with pneumonia. And we started our usual protocol, initially with hydroxychloroquine, and then we started the trial of high dose steroids. He was in very poor condition, not intubated, but on CPAP for many days, but fortunately we could win this patient and to taper the steroids, and is ready to be discharged. And these are so the two ends of presentation. This is an intermediate patient, same anatomy again. He came, I called him, he reported fever and cough. I kept him at home, but after 1 week, coughing was worsening, so I decided to bring him quickly to the hospital for a chest X-ray and hemogas analysis. The saturation was okay, the chest X-ray was okay, so we discharged him. I put together this patient because I think that they are very emblematic, because they are all complex patients around the same range of age, all male patients. What matters here seems to be the usual risk factor that are recognized in the general population, rather than the specific physiology, the specific anatomy. In particular, obese patients with comorbidities, poor compliance, bad lifestyle, and so on. So if we can just summarize some lessons that I had from this initial analysis, and probably when we put together the data that kindly Massimo gave me, we had more information, but his data I think are in the same line, they are confirming this. So probably the anatomy doesn't matter that much, the complexity doesn't matter that much. Probably is what matters is the lifestyle education, the social distancing, so the usual advice that we give to the general population. I think that this is also a good chance to learn. For me, was a great occasion, because I start saying that at the beginning of the history, we felt something unknown and very scary was going on. Now I definitely, that are in the middle of the battle, I definitely know that all this has changed it and will change my life forever. Something very dangerous, invisible, washed out my certitude and forced me to change my plan, to postpone my wedding and so on. But at the same time, it was a unique chance to be helpful for the patient. Last but not least, I would like to show this image. This is a picture which is in front of our hospital, and I will just take a few seconds for a thought about all the doctors and nurses that lost their life during their work because of this pandemic in Italy. Thank you very much.
Paolo, thank you so much for this. This is not just the uniqueness of the data and how they are helpful to the patients and trust, but also your personal perspective to this, and what a better example of through difficulty to do some good. So really appreciate that. Maybe before we go to Massimo, because we are learning from you here, and that's what we are, hoping to do, so then we can help patients here and elsewhere in the world. But maybe one or two clarification questions, and then we'll go to Massimo for me and for our audience, Paolo. Within this group of 90 patients that you had a clinical diagnosis of COVID-19, were there any patients with a frontal circulation?
There were, for my data, there are 2 patients with frontal circulation that had definitely symptoms. One patient was after conversion, so quite complex patient. He started to have very typical symptoms, some shortness of breath as well. It was an anticoagulated patient, was taking anticoagulants, so there was the Another issue was to adjust the INR in this situation. I was able to keep this patient at home and also another patient. So for the two Fontan patient didn't need any admission. And so far, this is now 1 month follow-up. They are doing well.
This is obviously the numbers are a little small, but something very positive for us and our audience. And the second question before I go to Massimo, clarification question. Paolo, I presume that you know that none of your patients in your books died through the pandemic. Is that correct? You have access. You know that there was no death out of your population.
No. So far, there is no death, yes.
Okay. Thank you so much, Paolo. Really appreciate it. And straight on to Massimo Chessa, who is the head of the Milan unit, polyclinical, which one of the questions, Massimo, is what can you learn from Italy? Give us, please, your wisdom, being both an ACST reference center for Italy and also a COVID center. Thank you.
Hi, good afternoon to everybody. And so what can I add after Paolo? So first of all, I want to give you a positive message. The positive message is that social distancing was able, from my point of view, from our point of view, to reduce the number of people with a CHD, Dutch people affected. Because as Paolo told you, the story beginning here in Italy at the end of February. And immediately, because the first zone was just in the corner of our hospital, few kilometers far away, we started to recommend our patients to avoid to come to our hospital to visit for the outpatient clinic. Secondly, we asked the most serious people like Fontan, people like TGA with specific atrial correction, to stay at home. And we personally did prepare a lot of certificates to allow them to stay at home, to avoid to work. I believe that this, what we did during the first weeks for some numbers of patients was really helpful. So we believe that social distancing is important. The second things we learned that from Greek people, because in Greece, the number of people affected, you may correct me, Michael, if I'm wrong, the number are very low comparing to the others. Probably they are still in the curve, but at the same time, colleagues from Greek are starting to ask us what is going on, what we are supposed to do. And they started with some very specific measure to reduce help the patient, ask them to stay at home, ask them to avoid to go work, etc. So we believe that also this confirmed that some specific issues are important. Third, what we learned, we still have in our hospital 2 patients. One is she's 53 years old. One is in his 40s, and both of them were operated on in our hospital just before the beginning of the story, in the beginning of February. So the infection was an in-hospital infection, a nosocomial infection. So what we learned? We learned that probably is important to stress very much to stress everybody, to keep distinguishing separating the two group of population, the COVID from no COVID, because the risk, like in our hospital, where all the hospital is a COVID hospital, but our center, the congenital center, is dedicated at the moment as a hub for all the patients of our region is probably not the correct way to manage the situation, because it's very difficult to keep a separation between the COVID part and the no COVID part. At the same time, in terms of severity, I can say that both of our patients are still in the ward. They don't need, they don't need ICU, they don't need ventilation, just a little bit of oxygen. One of them developed some pulmonary aspect of disease, but both of them are very well. One of them will discharge in the next few days. So I think some aspects, some positive messages. To keep on with the social distancing, very important. Second, to stay in touch with your doctors, with your cardiologists, and we found very, very, very important the help of our National Patient Association. They started in the beginning to do something every day, to post every day some specific information, some specific tips, and some specific awareness. We started as doctors, as physicians, to talk, to speak with all our patients, asking their questions using the web, using the social media. So I think we are still learning, but because now we are probably cross finger starting to see the light at the end of the tunnel. Maybe what is important is since the beginning of this specific step, as you are at the moment, think about the step number 2, how to sort out of this situation, how to organize the second step when the situation will be better. Because it's very important not to allow people to start immediately going work around because the weather is getting better. One final message. I received today lots of messages from my patient asking me, because after Easter, probably we will reduce our lockdown, we will reduce all the, we will allow people to restart work in some specific ways. They ask me what we are supposed to do. Are we supposed to go to work? My answer is no. Stay at home until at least for a couple of weeks more. After all, the situation will get better. This is my final message, Michael. Michael, your microphone, okay.
Can you hear me now?
Yes.
Sorry. Thank you so much, Massimo, for sharing your experience with us. And the data from Bergamo and from Milan, we must share with the rest of the world, because they're, correct me if I'm wrong, you give us a positive message that A, the measures that you've taken of distancing seem to pay dividends, and B, patients who were infected by COVID-19 seem to have done well and not running into big trouble as older patients with comorbidity do, ventilated and so on. So that's, I think, very, very encouraging. May I ask you very briefly, Massimo, you said that you're a COVID center. How did you manage to protect an area for congenital heart disease within your institution?
Yes, we create, so we have a separate ward just dedicated to congenital. We have 2 wings, one for pediatrics and one for adults patients, because we are taking care of all the congenital patients at the moment, not just for taking care of adults. We have a dedicated theater for where we are still doing emergency for from a surgical point of view, and also a cath lab available. we are a ICU dedicated, separated on the rest of the COVID part. But at the same time, the problem are corridors, common spaces that is very difficult because it's not a hospital built for infection disease. So we have common parts, and these parts probably are the reason why some of our patients, 2 of our patients, were infected. So that I believe that probably if you are organizing the way to follow your patient, it's better to have a separated, just a dedicated hospital without COVID patients.
Thank you, Massimo. Much appreciated. I think we should move to Rachel Adam-Smith, who is going to give us, she's an HHT patient, her perspective to this, and also she's got some questions to start. We must finish by 15 minutes past 3, so we have about 17 minutes, and there are multiple questions, but I will try to bundle them afterwards and address as many as possible. Rachel, thank you.
Good afternoon. Thank you very much for inviting me to talk today, Professor Gatzoulis. Obviously, I'm a mum to a 17-year-old severely disabled child who depends on me for all of her care needs. And like any other mum who has a dependent child, one of the issues, of course, is how we self-isolate from a child if they develop COVID or vice versa. In terms of like protective equipment, masks, etc., which I know you mentioned in one of your slides referring to breastfeeding, there's obviously stories about about the masks being limited. Is that an issue?
It is obviously a real issue for you, Rachel. I think the best thing that you can do is to physically distance yourself from exposure and thus protect your teenager daughter. Obviously, how can you do this? If you need to go shopping, you need to do certain things, you need to go out, maybe in Yorkshire you have some more space and you're not in a crowded area. But I think you need to recruit all possible help to protect yourself so then you can protect your daughter from exposure to COVID. I think that would be my advice. I think for the face mask, in general, their use is controversial. We don't have any guidance at present. And some of the studies are small numbers and conflicting. I think the advice about breastfeeding refers to obviously infants. The risk of running into trouble with a COVID infection is very small. I think it's different for you. So I think my advice, personal advice to you, Rachel, is to protect yourself as much as possible and you have all the help that you can get to achieve that.
Okay. So the next question I have relates to the exercise and social distancing. And I know what you say about physical distancing. For me, being able to go out and exercise is obviously really important, both in terms of mental health and physical health. And the problem that occurs, of course, is that cyclists and runners, unfortunately, don't keep that physical distance that is necessary. So I was wondering how much at risk we are by actually still going out. And I noticed what Massimo was talking about in terms of social distancing and whether in Italy people were still able to go out walking with congenital heart disease.
Let's hear what Massimo and Paolo have to say. Perhaps I don't want to monopolize the discussion.
Here in Italy, there is the common statement is that people are not allowed to go for walking. Up to now, the government has given very precise direction about it. So it's not possible for to go for a walk without a specific motivation, or you can go for running and so on. So up to now, at least until the 13th of April. That's the statement, because now, of course, it is a matter of priorities. Now, up to now, we were facing a lot of people dying, so the priority was to make some, to relieve the pressure on the hospital, just closing everything, just to preventing any possibility of contact. Probably we can, is something that is changing every hour, of course. Probably this direction can be changing in the future as the numbers will go down.
Okay, thank you.
Massimo, do you want to comment?
No, I think it's correct. I'm still convinced that social distancing also after the first step of this crisis will be important. We'll still keep people at home until more than the normal population. I'm still convinced on that.
May I also briefly say that we need to improvise, Rachel? You know, maybe in a confined space, you can do something like yoga or something else. And
Yeah, I mean, there's plenty of exercise videos, of course, and all sorts of things that.
Maybe go out at a time that there are no people around. Maybe.
Yes,
You know,
I mean, I went 7 o'clock this morning, and I know it's dependent on where you live, of course, as well. If you live in a built-up city compared to living in the remote countryside.
and it's also social responsibility to this, how all of us as people respond to this threat. But exercise is important. Yeah. Sorry, Rachel, you have more questions, please. You
Yes.
have practice.
Relates to ventilators. So there's obviously been lots of media stories about ventilators and a lack of ventilators. I know there's quite a lot of concern about people with congenital heart disease, and if they needed one, whether they would be offered one. I was just wondering whether you could shed any light on that at all.
I think at the moment, Rachel, talking for our service and how I see it, there is first of all capacity in terms of ventilators, albeit you may not have seen the peak of the storm as yet. And there is a lot of preparation, a massive operation with, you know, places like the Brompton being a COVID center with the Excel. So there is spare capacity right now. And I think clearly from what we hear from our colleagues from Italy, our patients have a good prognosis through this. So if our patients need intensive care and support, I think we're here to offer it to them. I think, again, the message from Italy is clear that we need to minimize exposure to COVID for our patients, as to ourselves, but mainly to our patients. And I think the operation that has been done on its head, not to see patients at clinics in good time, now third week running, but have this telemedicine, telehealth interaction. And also multiple questions here coming about the impact of deferring procedures, planned procedures on a patient's health. Many of the procedures that we do are elective on adult congenital heart disease. And the decision to defer them came after group discussion and making the relative risk of exposing patients to COVID come into hospital versus deferring safely an operation. So I think, and this model of changing sort of the model of care, as I said at the very beginning of my talk, is obviously very appropriate now and protects the patients, but some of it can be applied to once the crisis is over. We have to wait and see. But if a patient with congenital heart disease has COVID infection, in the first instance will be treated in the way that other patients are treated, calling 111. You know, here from Bergamo, this is a very positive sign that 88 patients were managed in the community, including 2 Fontan patients, and we had 3 patients with systemic RV. So I think that's very positive. And again, you can see the confusion about kind of the messages. Who is the high risk versus the moderate risk and what to do with it? I think every patient is unique. We need to assess every single patient, the patient, him or herself, with the providers, the local ACC team, and then see what is the best way forward for them. But you know, the infrastructure is here. We're here to support the patients. You're not neglected through this.
I think that just leads to one final question, which relates to obviously which specific hospital we should go to if there was an issue and we did deteriorate and we had to obviously go into hospital. I think there's concern about making sure perhaps we go to a hospital with an actual congenital heart disease unit as opposed to the more local hospital.
I think, again, you need to see the individual patient, the circumstances, Rachel. Some of the advice can be sort of provided by telehealth, either with the patient directly in some of the micromanagement, as opposed to bring the patient to a COVID risk environment, or with the local providers. So, for example, you're a patient of ours, if you needed, let's say, management of arrhythmia, for example, Rachel, I would be very hesitant against bringing you to the Brompton, albeit it's a long journey. I would find alternative means to manage you and protect you from getting COVID. And there are ways of doing it. But if you must come to the tertiary center and you get an admission of a patient, there's this very high selected population that need urgent HHD care, then we have a green zone, as much as you can fence it, as Massimo implied. It's a green zone, and that patient is with us from yesterday. And the same applies for patients that may need urgent cardiac surgery. There's a question here of a patient who had previous endocarditis. Just to answer this at the same time, what would happen if they get COVID infection? COVID is not endocarditis, and the majority of patients have a very mild clinical profile. But if that patient, let's say, gets endocarditis, not from COVID or not, and needs urgent surgery, we have Harefield, which is the designated center to accommodate. But we have to balance this against the risk of exposing you or any patient to COVID. So it has to be individualized. And we have round the clock, 24/7 team from us, the surgeons, the hospital, to look at it and support the patients.
Okay, thank you, Professor Gatzoulis. I think that's the end of my questions.
Thank you, Rachel. Really appreciate you with us. Maybe going through the panel, I don't know, Massimo or Paolo and Rob, if you wanted to sort of ask or between us, I have some more questions, clearly, many questions, and we have another 8 minutes. But is there anything that you'd like to ask about us, about...
just in terms of allocation of and escalation of therapy, just to spend a word of reassurance about that, because as I mentioned, we had a patient that came with poor condition, pneumonia. We had a discussion, and based also on this preliminary data that complex anatomy per se doesn't mean death, we decided to go for full medical therapy, including intubation and so on. So I think that the decision has to be made on the expectancy of life, general expectancy of life of the patients according to the age and other kind of comorbidity, but not related to the complexity of the disease or the anatomy, of course.
Thank you, Paolo. Do you have any other questions? So I'll start going through the list that I have here.
Michael, I think one of the issues is here in the UK, there's a lot of anxiety around this. I've received a letter and I'm shielded, versus someone else that feels they should have a shielded letter and they haven't. And I think some of the slides we've seen today sort of help people understand that they're not necessarily high risk. But maybe you could just give some clarification around that. I think if people think that they are high risk, what should they do?
I think that's a great question and point to clarify, Rob. I appreciate this. This is not about individual risks here. This is combating this threat by slowing down the transmission of the disease. This is the absolute priority, and the congenital patients are no exception to the rest of us. So this physical distancing principle that we must apply, stay home, is to slow down the transmission rates. So then there is opportunity for vaccination that may take a year. There is opportunity to have some more information about, for example, this intention to treat drugs, or very small data, the anti-malaria drugs that are used, and we use them also too. Opportunity for so-called herd immunity, the initial kind of thought or approach here, which obviously changed with further evidence. So then we ultimately beat this clever virus, because this is the first wave. Now, we hear from our colleagues from Lombardy that patients with congenital heart disease, even with more complex end of the spectrum, that they don't have additional risk factors, they don't have other comorbidity, seem to do well with the infection. Not that we want them to be the first to be immune exposed to it, absolutely not. So there's a positive message. We hear also from what Massimo tells us that there is some in-hospital infection, inevitably, even if you have green and red areas. So I think it is safer for the vast majority of patients to stay away from places of exposure. And as we see it in front of our eyes, to use more and more the technology for assessing patients. And also, I'll come back to this because this is not going to be over within the next few weeks or so. I put the slide to Greece, where I come from. I'm very proud of my roots, but I may not be able to go to Greece this summer. It's not the end of the world. And nobody knows when is the right time to relax it and the implications of it. And I don't think we can get clear guidance from China. It's just a different place. So I think we need to be very watchful of this, and we need time. And obviously, we are learning in the process. But I think staying at home is a responsibility for all of us to achieve the first primary target, to smoothen the peak and slow it down, if that helps, Rob.
Michael, there's a lot of very specific questions coming through on the system, and probably isn't enough time to answer those. I mean, maybe we can collate those and over the next few days put some answers to them.
Very happy to work with my colleagues, and I'm sure the UK and the international community in any possible way. We are with the patients in this. We are all together, Rob. And I have also numerous questions here, which is not possible to address today. But I think maybe the message that we can convey is that we are all together in it, that the patients are not neglected. Maybe there's a need of doing something like this in a month's time that will have more information, that we need to obey this physical distancing principle. I think for the individual patient, the approach that I have taken, if the patient is asking not to go to work with a background of congenital heart disease, I'm very happy to support them. If another patient who is not a high risk wants to continue, again, you need to look at individual patients. So we go around to Massimo and Paolo. Do you have any closing comments to make? Because I think in a minute and a half, we need to end this.
Well, as a last closure comment for my part is that another positive comment is during this crisis, what happened is that all the centers together around our region started to work together. So we tried several times to do that, where we needed the virus to push us to do that. It was very positive for the patients, because they can have a place that can take care of them really with all the physicians.
Thank you, Massimo. Paolo, do you have any comments to make?
Yes, I agree with Massimo. In particular, what the teaching is all this data. When I was collecting this data, I was reinforcing my belief that when treating patients with congenital heart disease, we should have a tailored approach, even in advising patients. For example, I just had a call from a patient, which is 25 years, follow patient, no medication, good ventricular function. He asked me if after Easter I can go back to work. Probably we can decide that he can go, provided that he is complying with the distancing, with the PPE and so on. So even the decision to reopen a little bit the to work and to the social habits and so on has to be made on individual guidelines according tailored to the patient.
Thank you very much, Paolo. May I thank gratitude to the panel and particularly to our colleagues from Lombardy. A big thank you to the Somerville Foundation, Rob. We're here.
My pleasure.
And thank you to Livemedia for facilitating this. And last but not least, thank to all of you who were able to join us live, but also the full webinar will be available, I think, on Facebook, YouTube, and Livemedia. Thank you.
Thank you.
Thank you.
Bye-bye.
Bye.
Thank you.
Safe.